Welcome to Singapore and Cancer 101, the fundamentals of cancer. Let's talk about staging today. Staging is a somewhat technical subject, and so we're going to be delving into the technical details, which might get a little boring. But for those of you who are interested, when you read your pathology report and when you talk to your doctor, things will make more sense if you spend a little time studying this subject. And since staging is very critical to your whole cancer situation, it's one of the most important things to understand. The American Joint Committee on Cancer, AJCC, typically sets up staging criteria for different types of cancer, and each cancer is different. They'll share similarities, but as you'll see today when I discuss colon cancer versus breast cancer, that the way they stage it is really significantly different, although with some commonalities. The AJCC often combines with a what would be like a research panel from the National Cancer Institute to set these standards. Now, you might ask, why do they spend so much time, and as you'll see, why is there so much detail about this staging? Well, as I mentioned in other videos, staging often affects your prognosis, so the higher the stage, probably the more poorly your prognosis will come out, the more chance it is that things will not go as well as you planned. So early stage is good, late stage is bad. But there are other reasons for this very technical way of staging. And one of the most important reasons is for clinical trials. So when you read medical journal articles, or when you're an oncologist carrying out a clinical trial on cancer patients, it's critical that you are able to compare patients. So if everyone's not using the same staging system, then when you read one journal article versus another journal article, you get confused about what's really being said. Can we really compare these two studies to each other? And so that's another reason why staging is so important to the cancer community in general. And finally, what are those clinical trials studying? Well, they're studying the best ways to treat cancer patients based on the stage of the different patients. And since stage affects many things, like your outcome, your likely outcome, then it's important that if I'm looking at stage 2 patients in this one study, I'm also looking at stage 2 patients in the other study, and that the two meanings of stage 2 are exactly the same. And so that's why everyone has agreed on the AJCC staging system for the most part. And that system is called the TNM system. T stands for tumor size, N stands for nodal involvement, meaning regional lymph nodes in the area have cancer in them or not. Like in breast cancer, the axillary nodes, meaning the armpit nodes, are often removed and looked at to see if there's any cancer in them. And if there is, then you would get an N1, meaning there is nodal involvement. And N0 would mean there is no nodal involvement. And finally, there's M. M stands for metastasis, meaning distant metastasis, meaning the cancer has not spread just to the lymph nodes, but has spread to the bones or liver or lungs, whatever, common sites of distant metastasis. But if there's evidence of metastasis anywhere, then you're given an M1 rating, as opposed to an M0, no evidence of distant metastasis. Now the first two, the tumor size and the nodal involvement, those are determined by a pathologist after you've had your surgery. So they get the tissue, both the tumor itself that the doctor has removed in an excisional biopsy, for instance, where they remove the entire tumor, plus healthy tissue around the tumor to make sure that, if possible, that they've gotten all the cancer. And then also the lymph nodes that they've removed in your armpit. And the pathologist, who is again the doctor who specializes in looking at tissue under a microscope, they go through that tissue very, very carefully and determine, first of all, is this cancer? Is it your standard run-of-the-mill breast cancer or something else? Also, are the lymph nodes involved? If there are lymph nodes involved, how many lymph nodes are involved? Another thing the pathologist does is looks at the gross characteristics, meaning not just the microscopic but the macroscopic evidence, part of which is the tumor size. And as you'll see in breast cancer, tumor size is important. And so what they want to do is measure the size of the tumor to greatest extent, in greatest extent. Tumors don't always come in nice round balls. They come in odd shapes. And so sometimes the tumor may be 2 centimeters by 3 centimeters by 4 centimeters, depending on which axis you measure the tumor on. And so your tumor size will always be defined by the greatest extent. In the example I gave, you would then be called, the doctor would say you have a 4 centimeter tumor, even though it's 2 by 3 by 4. And your staging would be assigned according to a 4 centimeter tumor. So where do you go for this detailed staging information? Well, you go to cancer.gov, cancer.gov, and you select your type of cancer. In this case, I'm going to be talking about colon cancer and later breast cancer. Once you've selected your cancer, look for treatment options. Once you're in treatment options, look for general information about treatment, or actually, I believe they have information about staging in there. So specifically a statement about staging, but this has to be in the health professional statement, not in the patient statement. They won't get into this detail. So let's talk about colon cancer, and I'm putting some stuff up on the screen so you can see it. So in this very detailed health professional statement on staging for colon cancer, it points out that older systems called the Dukes system and then the modified Asler-Collier system are no longer used for staging. Those were, 30, 40 years ago, a type of staging system that was developed specifically for colorectal cancer. But nowadays, as I mentioned, the AJCC has standardized these things, and now they use the TNM system, tumor nodal involvement, distant metastasis, TNM. And so let's look at what that means for colon cancer. So first of all, you often hear about staging in cancer and you think of stage 1, 2, 3, and 4. And that's pretty much typical. It's not true of every cancer. And many cancers actually have a stage 0, which is like a precancerous lesion, okay? Which may be removed or treated also to make sure that it doesn't develop into a more invasive type of cancer. So in colon cancer, there's a sort of surface lesion that's called a tumor in situ, and that's IN space SITU, and that's just Latin for in place, a tumor in place, just on the surface there. So for stage 0, the breakdown on the TNM system is TIS, small I, small s, for tumor in situ, comma, N0, meaning no nodal involvement, no lymph nodes in the area are involved, comma, M0, meaning there is no evidence of distant metastasis. Okay, and that would be classified then as a stage 0 colon cancer. Then there's stage 1. Stage 1 is defined as a T1 or T2 tumor and an N0 and M0, meaning, and T1 and T2 have a certain specification or definition, and I'm going to read that to you in a moment, and you'll see how detailed these things get. But if you're a T1 or a T2 and you have no nodal involvement and no distant metastasis, you're considered a stage 1. So I'm going to be looking down at my other phone here and reading what it says in the description for the TNM for a T1 versus a T2 tumor, so you can see what I was talking about. And I'm putting it up on the screen now. But a T1 tumor equals tumor invades the submucosa, which is a layer of tissue, through the muscularis mucosa, but not into the muscularis propria. Now, what do those things mean? What's a muscularis propria? Well, you can get an anatomy textbook or you can look it up online and see that it's essentially just different layers of tissue and generally deeper layers into the colon. And so it's progressing from the inside of the colon where the tumor begins on the surface, and it's going into deeper layers of the tissue of the colon. And of course, the deeper into the tissue it gets, the more serious things become. Now, a T2 says that the tumor invades the muscularis propria. So a T1 is slightly less invasive. The T2 has already reached this layer of tissue called the muscularis propria. But for a stage 1, it doesn't matter whether it was a T1 or a T2. All that matters is that it's a T1 or T2, and you will be included in stage 1. Of course, in this case, it's still N0, no distance, no evidence of nodal metastasis, regional metastasis to the lymph nodes in that area that drain that area of the colon. And there's no evidence of distant metastasis. And by the way, the pathologist determines the first two, the T and the N, because the pathologist is the one looking at the tissue under the microscope to see if there's cancer in any of that. The distant metastasis, the M in TNM, that's determined usually by scans and so forth. So the doctor will do a CAT scan or whatever, and he's looking for tumors in your lungs or in your bones or any evidence like that. So typically speaking, the M is either an MX, meaning the distant metastasis can't be determined or assessed at this time because maybe they haven't done any scans or anything. Or it's M0, which means there is no evidence of distant metastasis. Doesn't mean there isn't, it just means we can't see it. Or M1, meaning there is evidence of distant metastasis. Okay, continuing on with colon cancer, stage 1 is broken down into subcategories. Stage 2 is also, as is 3 and 4. They're all given like stage 2 can be stage 2A, 2B, 2C. 3 is the same ABC, 4 is the same ABC, and those mean different things about the tissue it's reached, what the situation is, whether there's localized spread, and so on and so forth. And you can read all those details about your particular type of cancer. If you don't have colon cancer, you don't really care about this. But I just want to point out the difference between how different the staging systems for different cancers can be. And we're going to talk about breast cancer in a moment, and you'll see. So the main thing here in colon cancer was really the layer of tissue that the tumor has reached, how deeply in, from the inside out, how deep into the tissue the tumor has gone. We'll see in breast cancer next that doesn't matter. What matters, for the T designation anyway, is the size of the tumor. So in breast cancer, when they're looking at a T1 or T2 or T3, what they're looking at is simply the size of the tumor in greatest dimension. So a T1, for instance, is between 0 and 22, or excuse me, 0 and 20 millimeters. Stage, the T1 designation is used for between 0 and 20 millimeters, which is 2 centimeters. So 0 to 2 centimeters. The T2 designation is a tumor whose size and greatest extent is between 2 centimeters and 5 centimeters. And then a T3 is any tumor that's larger than 5 centimeters. So you can see that's very different than the colon cancer approach, which is concerned with what layer of tissue you've reached. Here, it's simply measuring the size of the tumor. And you might say, well, why don't they do them the same? Why don't they have similar T designations? And the answer is, cancer is a group of diseases. So breast cancer is different than a colon cancer. We like to lump them all together, no pun intended, into just cancer. But in fact, when you're dealing with colon cancer, you're not dealing with the same thing as a renal cell carcinoma or breast cancer or a brain tumor of some sort and so forth. So what doctors do then have done with clinical trials and studies over decades is they've looked at what is important here. In colon cancer, it turns out that what's important for your prognosis and for your treatment options is how deeply the tumor has gone into the sublayers of tissue. Whereas in breast cancer, that's not the issue. The important, significant fact is how darn big is that tumor. That turns out to be the important characteristic that you're looking for in order to sort patients out and figure out how best to treat them. And just to close up, let's look at melanoma. a type of skin cancer, the most serious kind. There's also squamous cell carcinomas of the skin and basal cell carcinomas. Those are not particularly dangerous or concerning, and they're very, very common and easily treated. So let's talk about melanoma, which is a much more serious disease. In melanoma, they're not looking at the size of the tumor. They're not looking at the layer of tissue that the tumor has reached. What they're looking at is simply the depth of the tumor measured in millimeters, how deeply it invades into the tissue. So it's somewhat similar to colon cancer. But they don't talk about the specific levels of tissue that it's reached. They simply talk about the depth of the tumor. And your stage will then partly be assessed based on that. So as you can see, staging is a complicated, somewhat technical area of cancer, but it's also an important area, and it's not that hard to understand. Again, you can always talk to your doctor about it, or call the Cancer Information Service at 800-422-6237 and ask them what the, as you're reading the staging information, what does this word mean and what does that mean, and so forth. Or you can look these words up online. Anybody with a little effort can figure these things out. It's really not rocket science, but it does take some learning of vocabulary and so forth. So I hope this was helpful. Have a look at the cancer.gov site. Find your particular cancer. Go to the health professional version for your particular cancer and look under the treatment, and under that look under staging. And there they will give a tremendous amount of information about how your cancer is staged, but also they talk about tumor grading, which is another issue that I'll talk about in more detail in another video. Anyway, I hope this helps. See you in the next video.